many of you can tell me how many times you swallow in the course of a day? Anybody? Show of hands. Don't all yell it out now. Nobody. Amazing. A million. Amazing. You swallow 3 to 16 times per minute. 3 to 16 times per minute. That averages out to be 15,000 to 25,000 times a day. All day. Every day. Every one of us. And I find it remarkable that we know so very little about one of our basic life-sustaining functions. Do you share that? I'm amazed. And I didn't know anything about it really until I got into the field. And why would we know about it? It pretty much runs on automatic pilot. It's like blinking or breathing, coughing, sneezing. It all runs on its own until it doesn't. And that's what I'm here to talk to you about today. We're going to talk about, we're going to talk about not that. We're going to talk about dysphasia. Some people say dysphasia, tomato, tomato. It doesn't really much matter. Just remember that it's with a G. You will see that word with other letters. Inappropriately, G is what pertains to swallowing. And that's what we're going to talk about. Now, before, what's happening here? I have 3 goals that I want to share with you today. The first and the most important is that eating is one of life's great pleasures. Is it not? Through the ages, for thousands and thousands of years across all cultures. I was even told that I think Louis and de Medici, when they got married, 50 courses to their meal. Think about chicken soup. The first thing we do to show that we care, that we're concerned, that we're compassionate, that we're with you, is food, right? We eat. Isn't that great? The second thing is that the mouth is the first and the last frontier. Stop and think about this. How many of you had experience with babies, had babies, know babies, been around babies? Yes? Okay. Is it not true? It's the way by which children, babies in particular, first explore the world around them. Right? Everything in the mouth? We're not going into oral gratification. That's the other stage. We'll let Susan Milstein handle that. But it is also the last choice that many of you sitting in the room right now will make. To swallow or not to swallow. Because no one can make you do it. This is long after they bathed you, changed you, dressed you, gotten you up, put you to bed. After all those basic, everyday decisions have been made for you, and we know that they are because we're caring for people for whom we make those decisions. The one choice, the one power, the one decision-making power you will retain until the day you die is to swallow or not, because no one can make you do that. Think about that. Which leads me to the last topic, the last point that I hope to leave you with today, and I refer to it as informed compassion. I would like you to know a little bit more about eating through the various stages of life so you can help those that you serve as they grapple with decisions that they have to make pertaining to nutrition and to eating. All right? That having been said, and this was borne out because a colleague of mine today asked me what an SLP was. SLP is a speech-language pathologist. We're all healthcare professionals, providers in one way or another, but the fact remains that we are not our audience. And Detta, my business partner, drives this home every day when I do these talks. She said, "You are not your audience. Change that word. People don't know." Never assume. We think people know everything, but they don't. And when you work in the field for so long, you think that people know everything you know, because why wouldn't they? Never assume. People don't know what they don't know, and nobody knows everything. True, right? So in that framework, I'm going to talk to you about speech-language pathologists, because speech-language pathologists and social workers, how many social workers in the room? Show of hands. Thank you. Hold them high. Social workers and speech-language pathologists, we share this commonality in the healthcare industry. Nobody knows what we do. I mean, the average person thinks that social workers stand on a street corner and hand out sandwiches to poor people. It's the way it is. And when you say speech-language pathologist, they think that you deal with stutter and lisp. And we do. But it's not all that we do. We deal with speech, we deal with language, and we deal with swallowing. Okay, I've said that. You know that. But wait, there's more. When we deal with speech, we deal with articulation, we deal with diction, we deal with accent modification, which, by the way, is accent modification, not reduction in its proper terminology. We deal with the fluency disorders, including stuttering, cluttering, and lisp. That's what we do when we deal with speech. When we deal with language, we deal with word finding. We deal with how you put your thoughts down and how you express yourself verbally. That involves attention. That involves memory. That involves problem solving, sequencing, and the executive function of planning. Did you know about that? Did you know speech does that? Nobody does, but that's why I'm here. That's why it's a good thing I'm here. Now, and we also deal with swallowing, and people don't understand that either. In fact, people say to me all the time, huh? What's swallowing? And I said, you know, well, swallowing like eating, that's swallowing. I want to delineate the dietitian and the nutritionist because, you know, there are a lot of things people don't know. For example, if I say geriatric case manager, geriatric care manager, how many of you really know the difference? How many of us really know our references? Think about that. Did you ever think about that? I learned this. Case manager is generally in a hospital. A care manager is the one, those are the ones that we work with that coordinate care outside the hospital. Am I right? Correct me if I'm wrong. All right. Okay. Dietitian and a nutritionist, what's the difference? Any dietitians in the room? Any nutritionists in the room? Good, nobody will slug me, but here's the story. Dietitians, long story short, dietitians are always at least a bachelor's degree. They're all college degreed. In most instances, depending upon the various states, they have to be registered and they have to be licensed, all right? A nutritionist is a certificate program. All right, you can get a certificate as a nutritionist. Granted, they use those terms interchangeably, but the dietitian is the one with whom the speech-language pathologist works very, very closely, of necessity. And we'll talk about more about later. Speech concentrates on the how of swallowing. We're the mechanics. We want to make sure that it's going down safely. And your dietitians are the ones that work with the what. You know, how many calories, low sodium, no sugar, diabetic, cardiac, fluid restriction. That's what they do. They tell us how much has to get in and of what elements, and the speech's job is to get it there safely. That makes sense? And I can't tell you how many times people make mistakes, and somebody sent me, they wanted the nurse to do a training for, I work for a greenhouse model for people with disabilities, and they wanted the nurse to do training on swallowing. And I said, hold it for it. Hold it for it. The nurse doesn't do the training on swallowing. The nurse doesn't do the training on dietary consistencies either. But people don't know what they don't know, right? So now we're going to talk about how swallow works. How swallow works. It starts in your brain, believe it or not, and your stomach. They talk to each other. They decide that there's hunger there, right? You'll see how this all plays out. All right, so they develop this concept that they got to get food in the body. So then the brain decides, scopes it out with the help of vision, maybe, olfactory senses. It scopes out what's out there, and it decides what you're going to eat, how much, how quickly, and how it's going to deliver it to the mouth, right? And it goes into action. And then the food goes into the mouth. And on a good day, if you're lucky, the lips seal and it keeps everything inside so it's not drooling. And then your teeth start to grind. It's chewing it up, chewing it up, chewing it up. And your tongue is excreting saliva to moisten everything and form it into a ball, which we call the bolus. And then it gently pushes it back, that tongue pushes it back to the back of the throat like a spatula until it hits what we call the focal pillars. And that sends a message to the brain. It sends a message down here that says, incoming, protect the airway. So then this whole thing comes up and it'll cap flips over, the epiglottis flips over, and it directs everything into the esophagus on a good day. Just like a submarine about to submerge. Who knew? Who knew? And it happens in nanoseconds. And if you don't believe me, now you try it. Here's what we're going to do. Take your three fingers, middle three fingers, put it on your Adam's apple. Your Adam's apple, by the way, is where your vocal cords are attached. Swallow. Tell me what you feel. You're not doing it, Louis. Going to sit front row. Okay, did you feel everything go up? Yes. And everything come down? Yes. Okay. All right, we call that laryngeal excursion. Your swallower. Did anybody have it go up multiple times? Ting, 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 ting. That happens sometimes. It doesn't mean you're abnormal. Different, but not abnormal. As long as it works, we're good with that. Okay? Now, we're going to... No, that's not it. Didn't go in there. Okay. All right. What I wanted to explain is what's happening when your mechanism comes up. everything is tilting forward. And then there's a cap, a cartilage cap called your epiglottis. It flips over your airway. Your trachea is in front, your esophagus that goes into the intestine is in the back. And that's where the bolus starts its descent into the intestinal tract. It's kind of like the toilets. I hate this, but this analogy works. You know how when the flapper flips over, and if it doesn't flip over properly, it doesn't refill? And sometimes the chain kinks, you know, and then thing sticks up, that flapper sticks up. This can all happen with your, it's kind of crazy, but it's a good visual. This can happen with your swallowing mechanism. The epiglottis can stay up, the epiglottis can stay down, it can get stuck. They call that epiglottitis, by the way. That was in Medical Mysteries about a year ago in the Post. They didn't know what was happening, but remember that when that epiglottis caps over your airway, it cuts off your breathing. You stop breathing in the moment of swallow. They call that apnea. Momentary apnea, 1.5 to 2.5 seconds, by the way. I just learned that. Who knew? But the important thing is that this is why the frail and the elderly fatigue so easily when they're eating. Because they're already, most of them, having pulmonary and cardiac issues, and then you've got that thing closing off on them every time they try to swallow, and they get fatigued. Plus, we're trying to make sure it goes down the right hatch, all right? And that's also why gulpers, you probably have kids, maybe you gulp, you know, and then you're out of breath when you finish eating. That's why you're out of breath. That's what it's all about. And another thing, since we're on the subject, I'm going to tell you, is that for all of you who are out there, and I know you're out there doing this, some of you, we're not going to ask for a show of hands, but for all of you who are popping pills, medications, supplements, and taking that famous bottle of water and drinking with your head back, don't do that. This is not feeding time at the zoo. We are not designed like seals, you know, throw me a fish. That's not how we operate anatomically, and I'll show you in a later slide. That is not how we are constructed. It's very important to either keep your head straight or tilt your head forward ever so slightly. Because remember, you felt that laryngeal rise, right? And then there's this cap that's going to flip over. The more you put your head back, the further that has to go, and the harder it is for it to make contact and cover your airway, thus placing you at risk for aspiration pneumonia. It's not that easy. It doesn't happen right away. What happens is that you start to cough. Because when you cough, it's because something has gone into the airway. The airway is designed for air, and only air. All right? Now, when you cough, it can be something having fallen into the airway, or it can be something trying to come out of the lungs, like phlegm accumulation if you have pneumonia. Make sense? You getting the picture? I get excited about this. Who would think, you know? I don't have a life. Okay, what happens when it doesn't? I divide my swallowing issues into 3 categories. And this used to be rather, it was short and sweet in the community in which I worked. Whenever there was a problem, they'd say, what have you got? Did you see that person? And I'd say, yeah, and I'd call it out. It was either a can't or a don't or a won't. We did that already that time. And this is what I wanted to show you here. Let's see. See the epiglottis here? This here is your esophagus. This here is your airway. And this is the epiglottis that flips over. All right? And if it doesn't work, or if you put your head up too far, it can't flip over. Come on. There we go. Now, 3 types. The can't, the don't, and the won't. That can't be simpler than that, right? All right, so can't, think physiologic. There is something physiologically wrong with the body. What happened here? Oh my goodness, we've got floating in. I love these things that go on their own. Think dysarthria, a weakness like post-stroke. All right, that would be an example of a physiologic issue. GERD, gastroesophageal reflux, which is also known as chronic heartburn. Stenosis, has anybody ever heard of stenosis, esophageal stenosis? Okay, that happens when your esophagus narrows, and they can stretch it like a shoe. All right, what really happens, and I can tell you chapter and verse, I've been through a lot of these situations. What happens when they stretch it, though, is that they actually tear it a little bit, so there's a little bit of bleeding. And you have to be very careful if people are on Coumadin or other medications like that, where you have a a thin blood count. But anyway, that's your can'ts. They have a physiologic issue, and they might be responsive to therapeutic exercises, medication, positional dietary changes. These are the people that you're going to put on positional or dietary changes, maybe, after you see whom? A speech-language pathologist, that's right. And then, of course, you might have a medical intervention, the famous procedure like the esophageal stenosis that I talked about. The second group is the don'ts, all right? The don'ts think psychologic. When you think psychologic, what do you think? I'm thinking help. Help, come to me. Anorexia, bulimia, depression. Depression, people don't eat when they're depressed, right? Who thought about that? And how many older people do you know that are not depressed? But they got a pill for that. And if you've got a side effect, they got a pill for that too. And then if you're not eating, they got another pill for that. That's another program. We're not going to go into that. You also have the people with dementia who frequently hold in pocket. I used to be called in all the time. But you have to do this. You have to establish, you have to, a reliable source with the appropriate signature has to say, yes, this person is holding or pocketing. They'd come in and they'd say, I think Mrs. Jones is pocketing food. And I'd come down and I'd see, how do you, yep, she is. So what do? There are methods. There are methods. Again, the ways you work with that are positional and dietary changes, sometimes, but under the care of a speech-language pathologist, okay? Sometimes medication can help. It depends. It depends. It's comprehensive. We all work together. Is this making sense? Okay, we're going to talk about the won'ts, but we're not going to talk about them now. And you'll know why when I get to them. I'm going to have you punch my thingy here. It's not working for me. All right, they're doing a lot on pharmacology now. And swallowing and eating. And the one thing, and it's one of those things that this is intuitive, we would all know this, but we might not. If you notice a status change in somebody eating or not eating, suddenly not eating, be sure and check the last medication. If there were a medication change, be sure and check that. Because that, one of the side effects might be loss of appetite. It could be drying of the mouth. There could be a lot of reasons. So always check the last medication for the side effects. And again, you'd speak with the physician, nursing, but sometimes you have to be, most of the times we have to be our own advocates and we have to do our own research. So that's one of those key things you keep in your pocket. Remember to check that. I'll give you some other things that you need to check too. Okay, signs and symptoms of potential swallowing issue. Coughing. Frequent throat clearing. Sometimes throat clearing and coughing can be the signs of a more serious illness. For example, a gentleman, 34 years old, a bar in Bethesda, threw his head back drinking a beer, couldn't stop coughing. Early ALS. You just don't know what you don't know. And a lot of times it can be nothing, but wouldn't you rather know for sure that it's nothing? And even if it is something, wouldn't you rather get in there earlier and capitalize on all the residuals that you can maintain and strengthen forever and ever and ever for as long as you can to keep you going? Doesn't it make more sense? Watery eyes, perspiration, increased heartbeat. There are a lot of signs and symptoms. I had a gentleman once who, I turned my back for a second when somebody called me. He was at the dinner table, stroke patient. He stuffed mashed potatoes into his face. I mean, literally. But you couldn't see. He was very surreptitious. And his cheeks kind of puffed out, and we noticed his eyes watering. And I can still see the whole scene in slow motion as the nurse and I dove for him. He was in a wheelchair and wrapped our arms around him and gave him the Heimlich. He was okay. That was as close as I've ever come. I never want to get that close again. Things like that can happen. There's a difference between coughing and choking. For me, I distinguish. Coughing is not a bad thing, not a good thing. Coughing means that your body's trying to expel something from the airway. All right? The bad news is that it shouldn't have been there to begin with. But at least the body in its infinite wisdom has a way of trying to keep you safe. So it coughs it up. Choking is when your airway is occluded. Choking's not good. All right, that's when you have to resort to the Heimlich method. Diagnostics. We're dealing with an older population, and I'm getting more and more requests for this. Never underestimate the power of the clinical swallowing examination, and if you ever see any document, they're going to refer to it as a CSE, like the whole world knows what a CSE is. Don't you just hate acronyms? Oof. It is important, as with any intake, because it allows the individual, the speech-language pathologist, to meet one-on-one with that individual, to ask important questions. Was that person a social person? Did they like going out to dinner? Were they always finicky or poor eaters? What are the other issues? Are they happy? Are they sad? When I walk in and see a patient, the first thing I look at is to see whether or not they're smiling. And if they don't smile, can I get them to smile? It's huge. First thing on my list. But a clinical swallowing evaluation is the first step. It is not the only step. However, with the older population, as I'll explain to you, sometimes it becomes the only way because they don't want to do anything else, but that doesn't mean you can't help. These are the more common clinical diagnostic tools: the stroboscopy, the FEES, the MBS, which is also known as the VFSS, and I'll give you the spelling. The one thing I want to say at this juncture is people will come, and you've heard this, I'm sure, people will say, she passed the swallowing test. Did he pass? Did he fail? And my answer to them is, I don't know. Did they pass the CT? Did they flunk the X-ray? This is a diagnostic test. This is not competition. This is a picture painter. This is to let us know what's going on so that we can inform our treatment appropriately. The video stroboscopy you do in a physician's office, and it looks at vocal fold function. Many years ago, I tripped and fell in front of my dinner group. And they were all seated at the table waiting for me, and the chairs had pipes for arms. You can picture this. I took a step. I had the clogs, the rubber, it caught on the carpet, and I went down on my knees on the concrete floor with the indoor-outdoor carpeting, and I hit the pipe right against my Adam's apple. Yeah, it was everybody, it was one collective. Even those who were cognitively impaired understood that one. All right, got up, did my group, did my E-rising, up, and of course it was crackly. I went immediately to the doctors the next day, and I had them put a fiber endoscopic top, a video stroboscopy, and they looked at it and they determined that there was a little bit of bruising, but I was okay. This diagnostic looks at vocal fold function, which is important, but it's not the only horse in the race. The FEES is the fiber optic endoscopic evaluation of swallow. It looks at the swallow function. This, again, goes in through the nose, and speech pathologists are authorized to insert this. Put a little bit of lidocaine up there, and they pass the tube, and it goes down, and it looks at swallow function at the pharyngeal level, a little bit lower. Okay, not up here, a little bit lower down here. It doesn't focus on the esophagus. The esophagus is really important because a lot of times, like with heartburn, a lot of your problems are at the esophageal level. Now, ASHA, the American Speech Hearing Association, our governing body, has this wonderful law that states in black and white with a fancy code and subparagraph and this and that, that we as speech pathologists are responsible for the care and treatment of the upper 1/3 of the esophagus. Go figure, we can't even see it. So how do we get there? That's the modified barium swallow, otherwise known as the MBS. You've also heard of it called as the VFSS, or the video fluoroscopic swallow study. It all means the same thing. And this is the gold standard. And it's the gold standard because it goes down and it can reveal what's happening in the esophagus. You want a full picture. You don't want a half evaluation. You want to know what's going on. In order to have this study, you have to be at a radiology suite, generally in a hospital. You have to be with a radiologist in the presence of a speech pathologist, all right? And people don't want to move. A lot of our people have issues. Transportation is a huge issue, not the least of which is cost, all right? It's hard for them. When you get them there, if you get them there, you want a full picture. So for those of you who are care managers, I'm going to tell you what I told the physicians. If you really want to help us out, make sure that when the doc writes the script for a swallow study, that they specify A/P exposure, anterior, posterior. Because when they take a picture of a swallow, so X-ray, a swallow study is an X-ray of you when you're swallowing. They give you barium-laced stuff. You don't have to fast. They say hold it if they can follow cognitively. And then they'll say swallow, and the person swallows, and they take a picture. And they do it sagittally from the side. But what we want with an AP is for them to turn the person around so that we can see front and back, because it paints a whole different picture, and it's a much more complete picture. So remember that. When you're getting your script, rule of thumb, have the doctor put down AP. MBS is not the same as a barium swallow. Sometimes there's confusion. I myself was confused on that once because they ordered it for a family member. A barium swallow is to test the lower esophagus, okay? You have to fast for that. If I'm not mistaken, I think they administer that supine. You have to be lying down. They want to see exactly what your intestinal view is doing. And that's why I said the MBS is not the same as the BS, because in an MBS there's no fasting, and it's a sagittal view. And for the barium swallow, you're on a flat plane, and you have to fast. Things you should know. I think you know already that dysphasia is more than just a swallow. It involves so much more: the psyche, the attitude, the personal disposition, the personality, the environment. There's a lot of stuff that contributes to us wanting to eat and not wanting to eat. Us, think about them, the people that we serve, all right? A lot of times there are multiple comorbidities. You can have issues with cardiovascular function. You got pulmonary. Importance of oral care, and I have a representative here from Mobile Dentist. She came out. I cannot overemphasize the importance of oral care in aspiration pneumonia. It's not always about the swallow. Sometimes it's about really poor oral care, because all you need for pneumonia is for bacteria to get down in the lungs and multiply and produce. And it could just march right down there if your mouth's not clean. So I see people frowning. It's not all that grave. Just, you know, they tell me that if you rinse your mouth for 2 minutes, according to the American Dental Association, if you rinse your mouth with like Listerine or some anti-plaque and hold it for 2 minutes, it'll have an appreciative effect on the reduction of plaque. Did you all know that? I'm sharing that with you. No charge. Aspiration pneumonia. Words are a big thing with me. And in a course I was just attending, Dr. Jim Coyle out of Pittsburgh, brilliant man in the field of speech-language pathology, one of the gurus, and he said, be very careful about the term aspiration pneumonia. It's a little bit like Alzheimer's. You look at somebody and, oh yeah, she's got Alzheimer's. And I say, how do you know? You've got general practitioners who don't have a clue. How do you know that they don't have pervasive vascular disease, yet they're sticking Alzheimer? What a horrible, horrible thing to stick on a person's medical chart and try to get rid of it. All right, be very careful. Read those notes. You're entitled to read your notes. I've seen mistakes. I was quoted on things I never said. And the woman went back and raised Cain. You take that off. She never said that. Aspiration pneumonia is a term, it's a stigma, and it sticks with you on your medical records, and it buys the individual all kinds of stuff that they might not want, like, oh, we got to be careful for that one. I don't know if she can eat this. I don't know if he can eat that. Oh, maybe we should have thickened liquids. And all this happy nonsense. And they're talking about stuff they don't understand. So be very careful about the aspiration pneumonia. The other point, as I just told you, is that aspiration can be without pneumonia. You can aspirate. It can go down. But you don't necessarily have to develop pneumonia. By the same token, you could have pneumonia without aspiration. Okay? So it's not always. Be careful for the medical misuse. There are 6 drying agents. You should know those. Do you know what they are? In addition to medication and not drinking enough water? I'm going to tell you. It's chocolate, peppermint, coffee, tea, smoke, and alcohol. So if you suffer from dry mouth, like somebody else I know, biotin is a good thing. I meant to get biotin, the little drops. Don't suck on peppermint if your mouth is dry. Suck on citrus tablets, citrus lifesavers, any citrus candy. It'll stimulate your salivary glands down here. Help you keep your mouth moist. Do wonders for the breath as well.
Could you say them one more time, the 6?
I can repeat the 6. Indeed, I can. Think about tobacco and alcohol. We don't have a big problem, but of course we know how dry we get with wine. Some of us do. All right. Chocolate and peppermint. What did I say? Chocolate, peppermint, and tea and coffee. Tea and coffee. Now, I'm not saying never have them. I mean, if you go out for Asian food and you have tea, your mouth dries. It's a reality. It's everything in moderation and in good sense. And if your mouth is drying, it might be because of that. That's all I'm saying. All right? Aspiration precautions are very basic, and there are like 10, 12 of them. It's so simple. You take small mouthfuls. You chew well. You swallow properly. You should alternate solid liquid. When you're dealing with people that have issues, you start and you end with a liquid and you alternate. Make sure the person's in an upright position. A quiet environment. You can have music, but it shouldn't be anything with lyrics and rambunctious music. I had somebody that called me out once. They said, is it true you said they can't have gospel music? And I said, no. I said, it's true that I said I don't want any music in the dining room that has lyrics. I said, can you sit and listen to gospel music? And they said, well, and I said, my point. And I said, they can have classical, they can have light jazz, they can have anything that's calming without words. And when dinner is over, they can kick it up to high volume. But, you know, they were trying to set me up for that. I remember. And I know who. Medical administration at eye level. You know, I told you not to put your head back, right? And I'm going to use a handle here. What's the first thing the nurses will do? They'll come up and say, hi, Miss Smith, I have your medication for you, right? And they're standing over this person, and the person's looking up like this, right? Tell me you've never seen that before. All right, everybody should be on those little sliding chairs. Tifa Snow does this wonderful thing on how, you know, you put your hand under their hand, because if they have dementia, you've got prefrontal cortex disability there, and you don't always understand the motor coordination. You don't know that that's your hand, but they know that this is their hand. But if you put your hand under and help them, so they only see their hand, they won't know that they're getting an assist. So they're a lot less reluctant to push you back. You have people that are spitting out their medications all the time, right? So they crush them, right? Okay, worst thing. Then they're walking around and they're spitting all the pieces out, right? So they put it in pudding or applesauce. Remember that we have 10,000 taste buds, and they say most of them are gone by the age of 60. I hope not. I hope that's not the case. But the one sense that remains is sweet. So try jelly. Give them a jolt of jelly. Put their medication, I mean, if you've got to crush them, put them in jelly, because at least they'll be able to taste that. They'll be able to feel it. It'll hold together. It's got some viscosity. Minimize distractions. There's a difference between content and social discourse. And I'll get into that later with my story on Tony. People will say this person isn't eating. And the first thing I look at is I say, is this person voiding? Because what goes in has to come out. And a lot of times with medications, people are anticholinergic, so people are constipated. You know, they're not eating because it's not coming out. And they're just feeling all stuck in the middle. I had another situation where the woman was all crunched down in the bed. I came over and I pulled her up. Problem solved. You know, these logical things. And the other thing I want to speak to is the PEG, the idea of alternative feeding. Once a PEG doesn't mean always a PEG. But think very carefully about when you're going to insert that feeding tube, because it's a tether. Remember, first on, last off. People do not understand this. Remember that when you're dealing with dementia care, the first thing you learn is the last thing you're going to lose in life. First on, last off. Consequently, people are going to resort to eating with their hands, because it's what they did as children. They're going to do a lot of things. They're going to start calling you by a sister's name or a mother's name or a father's name because they remember that person. And it really doesn't matter as long as they're happy, as long as they're smiling. Remember that they have a reduced field of vision. The vision becomes binocular as they get older. There's a yellow tint. So we give them pureed mashed potatoes on a white plate. How cool is that? You know, they can't see it. And then they don't understand, so they're stealing somebody else's food. But they're not really stealing somebody else's food. If you've got binocular vision, you can't see. So you grab the first food you find. And generally, it's on somebody else's plate. Personal space, we'll get into that. Okay, familiar situations, and I know this is probably what a lot of you want to know about because you're dealing with this every day. Removing and spitting food, I talked about that. People get older, when they're on a modified diet and it's puree, they want it puree. And if there's one lump in there, it's going to be an issue. You just have to be very, very careful that it's pureed. Okay, they remove and refuse their dentures. Why is that? Because they're losing muscle tone and they're losing weight, right? Their body's morphing, it's changing. And one of the first places you lose weight is in your gums. Who knew, right? Now there are pads that you can, liners that you can put in your dentures. They don't always work. And you know, sometimes long and short, it's just easier without. And is that so bad? You know, they don't have that filter system. They don't care if their makeup's not right, the tie isn't straight. You know, life is good. It's just about the quality of life. They hold in pocket because sometimes they have diminished sensory awareness, and because of their prefrontal cortex, they don't have the mechanics to understand how to get it out, how to clear. They can't get the tongue to do that anymore. So there's solutions for that. And who can help you with that? Okay, all right, just checking, just checking. Now I'm going to talk about the wounds, and this is the subject near and dear to my heart. This is the group that is least understood. And this is what I want you to study very, very carefully. People do not die because they stop eating. They stop eating because they're preparing to die. I'm going to tell you about my friend Tony, dear friend of mine. She called me at 7 o'clock in the morning. I'm glad she could call me. Not everybody can call me at 7 o'clock in the morning. She's hysterical. She said, Mother can't swallow, she won't eat, I need you. Background history, Mother's 96 years old. 14 years post-diagnosis of Parkinson's disease. She's been, I know you're shaking your head. She's been living at home under the care of a caregiver 24/7 for the last 10 years of her life. Somehow she falls. And in helping her up, they break her neck. So now she's in the hospital. Broke her neck and her hip, I think. So she's in the hospital, right? And her daughter's hysterical. And she's, I don't know what I'm going to do. Mother's not eating. She can't swallow. And I said to her, well, what is it? Is she not eating or not swallowing? Well, I don't know. She's just not taking food. Well, let me tell you. There's a difference between somebody saying to me, oh, honey, I could go for a Reuben. Oh, I could go for a burger. And her saying, oh, Mother, this applesauce, this Jell-O looks so refreshing. Wouldn't you like some? And her saying, uh-huh, honey. Because people maintain that social nicety. They can carry on conversations. First on, last off, please, thank you, how are you, nice to see you. And they don't have a clue, all right? I could not diagnose, nor would I over the phone. I asked her where she was. She was in a very reputable, have the doctor spoken to you? No. I said, has a speech pathologist been in yet? No. I said, how is she getting food? I don't know. I don't see why they can't just give her the IV. They can't feed you through an IV because your veins aren't strong enough to support nutrition as a primary source. It's not going to work. And I said, well, you need to talk to your doctor and you need to find out what your doctor recommends. But on a personal note, if they say the word PEG, I would probably say no. Is Mother cognitively impaired? No, 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 Mother's fine. 96, 14 years post-Parkinson's. She said, I just can't let Mother starve to death. And that's when I stopped. I said, starvation, you know, is a very emotionally charged word. I said, Tony, I will give you my word on this. Your mother will not starve to death. She said, really? I said, no, your mom's not going to starve to death. I said, she's not eating because she doesn't want to. And I said, that's okay, because what's going to happen, long story short, I said, her fluids are going to go into tilt. That sodium is going to take over. It's going to push her brain into such a level of euphoria. Man, she's going to be on a trip that people paid big bucks for in the 60s and the 70s. And she said, really? And she started to laugh. And she said, really? And I said, the body is a wonderful machine. It has a tremendous way of helping itself. Listen to what your mother wants. She'll let you know. Pay attention. Just know that she will not starve to death. And she will not be in pain. And I said, and talk to the doctor, let me know about the rest. On another note, my mother was a naturalist. We had property in Wisconsin, and she was always bringing home critters. One day she brought home 4 baby raccoons. Their eyes were still closed. Of course, Mother had been killed in a trap, so we commenced to feeding the raccoons because these were babies and they had to be fed every 3 hours. So my mother, father, and I were out there with baby bottles and pipettes doing, you know, we weren't exactly experienced in the area of raccoon rescue, but we gave it our best shot, only to learn that the pablum wasn't strong enough. There were 3 little boys and a little girl. We would lose 2 of them until we got it right, but we got it right and 2 survived, and it's a lovely story, and I can tell you about that later, but it's really neat. Nature's great. We can learn a lot from nature. and from animals. So I remember when the first one was struggling, was in the throes of expiring. And my father and I desperately are trying to feed this little critter. And my mother just looked at us and she said, and I've never forgotten this, 40 years, 50 years post, she said, I don't understand why you insist upon forcing nutrition into that little creature when all he wants to do is die. Let him go. Make him comfortable. His last few moments shouldn't be a struggle. Think about the raccoons. Which brings me to my next issue, and this is where I'm on my soapbox. How many people here are from hospice? Okay, I salute hospice. It's the closest thing we have to death with dignity. Let me say that. I have a serious issue with the use of atropine. Atropine is a pharmaceutical. It is used to dilate the pupils. It's also known as belladonna, beautiful woman, because of the effect it has on dilating the pupils. It's a drop, and those pupils get so fixed, like those cartoon characters that are love-struck and, madly in love, with the circles going around. That's the effect that it has when it dilates the pupils. It's also used in germ warfare, biologic warfare in the injected form, to maintain airway patency. Think what it can do. Think what it can do. All right? They use it preoperatively for secretion management, so people don't have issues preoperatively, or during the operation, during surgery. But it's also used by hospice for end-of-life care, and I have a real serious issue with this, and I'm going to tell you why, and you can make your own decisions, okay? They use it probably for the same reasons, to maintain airway patency. They use it to manage the death rattle, and they use it for secretion management. Okay, here's the deal. Airway patency, according to the research that has been done, there is a very low level of respiratory distress in the dying patient. I can give you the resources for that. Nobody really knows what causes the death rattle. It's when fluid gets stuck in the hypopharynx and it sounds like somebody's underwater, and it's enough to scare the hell out of you. And it's particularly frightening for those of us who are caring for the individual because we want to help and we don't know what to do. So we panic, right? And I've had people from hospice tell me that they really give it so that the family is calmer because they don't like to hear the noise. And I said, okay, so when I'm under stress, I get a really bad headache, so why don't you take 2 aspirins so that I'm not under stress right now? All right? And she smiled, and we understood each other. They use it for secretion management, and this is where I have a huge issue. They use it, and I've had 3 patients on hospice, and I had all of them, they all discharged, and one went on to live 2 years more after a rapid status change with 1 dose. What happens is with secretion management, when people are drooling and that gurgle with the death rattle, they put it in droplet form. It's authorized for hospice for use sublingually. So when they put it into your mouth, it dries up the salivary glands. Okay, now think about that. Swallowing is your last choice, all right? Can you swallow dry? Can you think about how frightening that is at the very end when you're depriving a person of a basic autonomic response? I don't consider that quality of life, and I don't consider that comfort care. That's just my opinion. And what a lot of people don't know with regard to this medication and any other medication is you can opt out. You can ask to have it discharged. Just know why and know what and understand. It's all about being the informed consumer and the informed advocate. Now, as healthcare professionals, here's my theory. As healthcare professionals, we have to learn how to educate and inform those that we serve so that they can make a timely decision for their appropriate care. We don't make the choice for them. We empower them to ask the appropriate questions and make their decisions. As a country and as a culture, we have to embrace finality. Nothing lasts forever. And sometimes there just ain't no app for that. And even if there is, it doesn't necessarily mean you should use it. Just because you can do something doesn't mean you should. This is an issue that is resonating. You'll see it in the literature. Otto Gawande just wrote on Being Mortal, a book on it. Bruce Wilson, a well-known cardiologist from the Midwest and out of Chicago, he has now gone into palliative care, and he says the same thing, that we are on this fix-it mode. We have to fix everything, and we have to do it now. And you know, sometimes there's a lot to be said for let it be. You have to weigh the system. As individuals, we have to join together, and we have to help each other and those around us embrace these changes, because we're a support mechanism for one another. This is the most important part of life. It's the final chapter. It's the most important part of any book. And we need to safeguard the right of the individual to write that chapter. Don't you think? Getting really heavy, right? People don't die because they stop eating. They stop eating because they're preparing to die. This is what I mean by informed compassion. I wanted you to remember that the mouth is the first and the last frontier. How are we doing? Are you with me? I'm not done. First of all, I want to thank Rose in particular, because this is the first time I've ever, I don't know if you ever knew that I knew anything professionally, but I have some knowledge, okay? I want to thank the programming committee in particular, and I want to thank Jonathan specifically, because he is the one that said, whoa, this is important, we got to do this. And so I'm grateful to you, Jonathan. Thank you, my friend. The most important thing, eating is one of life's great pleasures. Nobody should suffer in the process. Don't you agree? Especially when they don't want to. Thank you. Do you have time for questions?
Thank you, Susan. It was wonderful. Questions for Susan? Right there.
Erica.
What happened to Tony's mother?
She died.
So that was
She died 2 days later. They didn't peg her, but Tony was at peace because I gave her a vital piece of information. And that's one of those situations, all of us in healthcare. We've all seen this situation. Anybody could have started the conversation. Everybody should have. Somebody surely would have. Nobody did. Just saying. Anybody else?
First of all, thank you for the presentation. It's wonderful.
Thank you.
I have a question. My mom has advanced early dementia, and now she's on they're giving her Ensure, and so she's only able to drink from what we know, and she's not able to speak. So we don't know if it's the medication that she just doesn't want to eat. So my question is there any way that she's just forgotten how to eat and that we can reteach her again? No.
She probably, this is long story short, and again, you're asking me for a clinical diagnosis on a patient that I haven't even seen, which is unethical, but I'm telling you, in answer to your question, yes, it is possible that she's forgotten how to eat. It's more than likely. The important thing is to regulate pain. I don't know how old she is. See me later and I can give you some recommendations. Okay? Anybody else? Are we good? Buon appetito!